retinal dystrophies, but about my own, seeing beyond, a structured approach to phenotyping to genotyping in IITs. So this talk is rooted in clinical stories, personal milestones, and the belief that careful observation can change the lives. Before I move forward, I want to pause for a moment of gratitude. This is Professor Vishambar Rasguru, captured just a few weeks ago. For many of us, Odisha ophthalmology, Professor Rasguru is not just a name, he is a legacy. His work, his teaching and his uncompromising commitment to patient care have saved the very foundation on which our generation stands. So the oration named after his owner is not just here. This was the first environment that shaped my discipline, my work ethic and my sense of belonging in medicine. Fast forward to 2015, after my internship, I went to AIIMS New Delhi. My first indirect ophthalmoscopy at AIIMS, here you can see in the left side of the image. A simple movement captured by a friend, but it felt like opening a new door in my life. In 2016, seeing my work featured on the cover page of RPCML book was more than recognition. It was validation that I belong to ophthalmology. And in OT, experimenting with red cam and capturing the unforgettable group selfie, these smile, joyful moments were the ones that carried us through the long days. So there are many memorable moments at AIIMS Delhi. Holi taught us color. The annual function taught us community. The final PG exam taught us humility. And the convocation that taught us gratitude. That photograph with my wife still reminds me that every academic milestone is supported by someone silently cheering from the sidelines. So this slide is simple. Here my professional journey began. It just says focus literally, and that's exactly what Vitretina taught me. Patience, precision, and the ability to stay calm when the world is magnified 25 times through a microscope. And sometimes it taught me to be a JD. This is one of my favorite photos because if you look closely, it captures more than a surgeon. It captures someone who has finally found where he belongs. Behind every confident fellow is a faculty member pretending to stay calm. Fellowship was where knowledge met humility and where confidence met responsibility. These were the years that transferred training to identity. And today, standing with my colleagues at LPP, I am reminded that careers are not built overnight. They are built through people, mentors, peers, students and patients, each shaping us in a way we often don't realize. So I will begin with a quote. We do not see things as they are. We see things as we are. Respected chairs, seniors and colleagues, I wanted to begin today with a thought, a reminder that vision is not just about light entering the eye. It is shaped by who we are, what we know and what we choose to look for. And nowhere this is more true. The image is not about disease, it is about world we live in. Quite literally, this is the World Atlas of Artificial Night Sky Brightness published in Science Advance in 2016. So it shows that more than 80% of humanity lives under light polluted skies. Under the yellow and red zones, night is no longer dark. The stars have been drowned by our own globe. So when we zoom into the Asia, including India, the picture becomes even more striking. Much of our population lives under skies where natural light is degraded, often beyond recognition. And that ironically is exactly what happens in inherited retinal dystrophies. The universe is still there, the light is still there, but the person cannot see it because something within blocks the signal. No pollution in the sky, but disruption in the retina. Because true clarity in IRDs requires us to look deeper than visible. Ladies and gentlemen, today I invite you to a journey into a group of diseases that challenge not only our clinical skills but our very understanding of vision itself. Inherited retinal dystrophies are not just conditions of the eye, they are stories of biology, resilience and human hope. And in these patients, what we see is rarely the whole truth. We must learn to see beyond. IITs affect children, young adults and entire families. These are chronic, progressive and deeply personal diseases. Our duty is not only to diagnose them but to understand them fully. So if you see what is the most common cause of blindness which is evolving in younger population or working age group? It is IRD now. So after joining LBP, one of the defining experiences during my fellowship was 2 months rotation at the Raigada Secondary Center in Odisha. This was the first time I got hands-on exposure to secondary level eye care and community outreach in a truly undeserved regions. Working in Raigada helped me to understand the ground reality of eye care delivery. This experience strengthened my foundation and made me more empathetic and gave me a deep appreciation of LBP's pyramid level. So during this period, I also became involved in a major population-based research initiative of Tribal Odisha Eye Disease Study, also called as OS, which covered an extraordinary cohort of more than 76,000 people. So one of the key findings in our report was the significantly higher burden of retinitis pigmentosa in the tribal community. As you can see here, RP affected 20% of the tribal population as compared to 6.4% in the non-tribal group. So the difference was both clinically and statistically significant. This study shaped my early interest in inherited retinal dystrophies, which later became a central part of my academic learning. Building on the early momentum of the TOS study, my journey of inherited retinal diseases continued to grow organically through multiple clinical and research collaboration at LBP over next 2 years. Here I am quoting 5 or 6 studies, so that I have got the opportunity to contribute to several important publications. They expanded my understanding in prevalence, clinical characteristics, and electrophysiological features of various IRDs. So I'd like to begin with a thought that has guided almost every step of my journey. Louis Pasteur once said that in science, observation is the first and the most powerful step towards understanding. For me, this couldn't be more true, especially in the field of inherited retinal diseases. So one of the reasons I love working in IRDs is frankly the retina is beautiful. Look at the images, how beautiful they are. So here is one of the more fascinating paradoxes we see in IRDs. On the top, you see a retina with an extremely severe pan-retinal phenotype, pigment migration, widespread atrophy, and a textbook feature of advanced disease, and yet this patient sees 20/20. Below, in contrast, the phenotype appears far less dramatic, but changes largely confined to the macula, with periphery looking almost normal, but this patient struggles with 20/100. So this is why I often say in IRDs, the fundus doesn't always tell the full story. Severity of the image doesn't equal severity of the vision. So every time I read about Theodore Lever, I am amazed by one thing. So more than 150 years ago, someone was so enthusiastic, so observant, and this committed to understanding blindness at a time where ophthalmology had no imaging, no genetics, not even basic tools that we take granted for. So this sparked some curiosity built in the foundation we now stand on. So when we talk about IRDs, we often focus on retina, but sometimes the body gives us clues far beyond the eye. So look at this paper. This paper is a perfect reminder. CNGP1 associated retinitis pigmentosa. So it is not just a retinal disease. So almost all patients in the study have significantly reduced or absent sense of smell. So it is subtle, it is unexpected, and it's incredibly important. Because this tells us one thing very clearly, systemic history matters, especially in cases with IRD. So when I went ahead and asked all my cases with CNGP1 associated retinitis pigmentosa about can you smell normally, the answer was no in all my 5 cases. This was a significant finding that I missed when I initially saw these cases. So let me tell you a few stories of phenotype that really put me in paradox when I was going to diagnose diseases. So look at this image. So what you can see in this image, you can see some amount of very serpiginous kind of atrophic changes. The peripapillary area is spared and macula is involved. When we subjected this patient to electroretinogram, so there was definitely cone predilection. So cone was more affected than the rod. Similar age group, similar vision, another patient. So look at the fundus image. Here also similar kind of picture, you will see macular atrophy, peripapillary sparing. So in place of this amoeboid kind of atrophy, we see this fist flex. And electrotyping, again cone rod affection. So what it could be, when we genotype those patients, the second patient had ABCA4 related Stargardt, and the first patient was RDS12 related Leber's congenital amaurosis. Two different spectrum of disease presenting as same. So if you see the visual cycle, so one enzyme is located in the inner segment, the other one in the outer segment. We published this in Ophthalmology Retina. Stop. I think it's not ready. Yeah. So another case. So the fascinating case of a patient whom we followed up to 10 years. So see, at the age of 4, we can see central macular atrophic patch. So initially this patient was diagnosed to have macular dystrophy, but over the years the excavation progressed. So this we attributed, and when we patient subjected to genotyping, there was some mutation in the RD3 gene. So RD3 gene is a homeobox protein that helps in macular development. So what initially diagnosed is a case of macular dystrophy, later on diagnosed to have RD3 mutation. Similar kind of picture, macular coloboma along with this subtle inferior pyramidal triangular changes. So this we collaborated with Amsterdam University, and this is a variant that we found in our cohort, this secondary to BSX2 mutation. Again, going back to the PG base, there was macular coloboma, retinal detachment, posterior occipital encephalosis. So obviously this is a case of Knobloch syndrome secondary to collagen 8 mutation. So we talked about focal alopecia. Now see this girl with extensive alopecia with finger abnormality and macular coloboma. So this is again a case of CBS3 mutation related associated juvenile macular dystrophy. So phenotypically these patients may look similar, but genotypically they are completely different. One more interesting finding that I noted in a case of RPGR. So RPGR is an X-linked retinitis pigmentosa. It affects exclusively males, and the females are carriers. You won't see any subtle change. So what we noted in our population, especially in Odisha, all these patients with RPGR mutation they do not express themselves. So they express or they behave like female carriers. So this data I presented at the ISEP, and I got ISEP travel in this year. So I'll skip this case. So one more interesting case, when you see a patient of retinitis pigmentosa with polydactyly, the diagnosis is very simple, Bardet-Biedl syndrome. So what we noted in our cohort, we had very higher number of cases who presented with ocular coloboma. So ocular coloboma, Bardet-Biedl syndrome, is there anything which is related to ciliary development or iris development? Yes. We kind of connected the signals, and the signal connected at the Hedgehog signaling pathway. Finally, through phenotyping, we gave a novel classification for the gyrate atrophy based on zones of disease, and we tried to correlate with the macular edema development. So before we go deeper into the sentence, science, I want to pause on this philosophy that guides this entire oration seen beyond. So remember, phenotype is not equal to full truth. Localized findings may hide global diseases. So phenotyping should be the starting point, followed by electrotyping, and followed by genotyping. And finally, genetic counseling. When a family hears that the child has an inherited retinal condition, the first questions are, why did this happen? Will my other children have it? Is there anything we can do? So genetic counseling exists to answer exactly these questions. I'll take one. So let me share a story that has stayed with me. The story of two brothers that walked into our clinic on the same day. Two children with same home, same parents, same world, but two very different experiences of vision. This is the older brother, serious, reserved, trying hard not to show how much light bothers him. And here he is again, suddenly more comfortable with the movement we use red tinted glass. Below is the younger brother, smaller in age, but not in courage. But when we try to use tinted filters for him as well, you can almost see the relief. I just wanted to show the video here. Here you can see there is movement that stayed. You can see the expression once the red tinted glasses were put. You can see the child was visibly very happy. So this simple small things can treat. So this is a case of achromatopsia with CNGA3 mutation, which is very common in our population, especially eastern part of India and in Odisha. So finally, after speaking so much time with patients, family living with IRD, one question that echoes in the room: Doctor, is there any treatment? For years, our answer was cautious, but today the answer is slowly but surely changing. We hear from Dr. Santosh also the role of optogenetics in these conditions. So standing before my last and final slide, standing before the statue of Donders in Utrecht, the man who coined the term retinitis pigmentosa, he named the disease. So I hope to spend my whole life understanding it. Thank you very much.
Sir, fun.
Have been a great visionary to have glaucoma genetics. So I hail from an APICS tertiary eye institute, AIMS RT Center, and I have done my graduation, my post-graduation, as well as being a senior resident and thereby later on faculty at RT Center. So it all began when I was at the Royal Victoria Eye and Ear Hospital, where I was doing a fellowship in glaucoma, and I was primarily seeing patients who were 60, 70 years old in comparison to the patients that I used to see in Delhi, where all the glaucomas were less than 50 years, or in fact most of them were less than 40 years of age, and I was wondering why in our country glaucoma is happening at such a young age. So that is how, when I came back, I started realizing that I need to work on this much more. I was seeing a lot of patients with juvenile open-angle glaucoma, and this led into my journey of glaucoma genetics. So why juvenile open-angle glaucoma? In our part of the world, it's not so uncommon. We do get to see at least about 3 to 4 new cases for every 100 patients that we see. Unfortunately, in the West, not much was known about this disease, and the long-term management of this subgroup was important because it was someone's father, it was someone's husband, it was someone's child, it was a socially productive age group that we were dealing with, and the economic costs and the economic burden of blindness was huge in this. But the most important part is the entire glaucoma genetics began from juvenile open-angle glaucoma with the discovery of the myosin gene. So in our part of the world, as we know, especially in a tertiary center like ours, we get a huge number of patients, we get very complex patients, and therefore the numbers are so large that over these years I have been able to accumulate almost like 800 families with juvenile open-angle glaucoma, which is probably one of the largest in the world. And these are a lot of my publications just dealing with the glaucoma genetics, because there is so much of genetic material that we are dealing with, including the fact that we published or discovered a new gene for glaucoma. So the essentials of genetic evaluation include correct phenotyping of a patient, and of course deep phenotyping them, forming pedigrees, trying to collect as much DNA sample as you can from the first degree relatives, and then finally sequencing and interpretation of those results, which of course takes a lot of time, money and commitment. And during this whole process, I did not know. I was a clinician, I had no knowledge of genetics, but I started doing genetics over a period of time and I became a geneticist. But during this journey, I was helped with by one of my colleagues, who is Professor Arundhati from the Department of Genetics, who guided very quiet. Dr. Arundhati Sharma, who helped me during this journey, as she had a lot of knowledge of genetics, and she helped me during this whole process. And also is Dr. Arnab Panigrahi. He belongs to Odisha. He's a resident at the moment, but he's full of energy, full of life. And every patient he would bring to me and he would ask me, "Sir, iska genetic analysis kar lete hain, he's interesting." So this is how the tempo went on, and we kept on doing a lot of genetic studies, and I'm going to go through with you about how this whole journey based on different cases came about. So the genetics of any particular disease is just the tip of the iceberg, because there's a lot of things that we do not know and a lot of things that we want to know. But But if you have to look at one particular base pair in a millions of base pairs, it is like finding a needle in a haystack. But the return of investment is huge. I mean, even if one family you are able to diagnose and screen, it's a lot of amount of money that goes into benefit. So this particular case, this is a case where the patient had glaucoma at a very young age, very high intraocular pressures. You can see there is a 360 degrees posterior embryotoxon. So this is a classic case of an Eisenfield-Rieger syndrome, and if you look at the phenotype, probably you would not even need a genotyping, because essentially these are the two particular genes, the FOXY1 and the PILEX2, which are most commonly involved in this particular disease. And then it is this case, an aniridia case with subluxated lens, and again, a real genetic diagnosis is not required because invariably they have PAX6 mutations. So which brings us to the fact that there are certain diseases for which we actually need a genetic diagnosis. This is a classic case of Peters syndrome, where you can see it came on ASOCT, and this child had Peters gene. But there are certain conditions where you need a genetic evaluation to make a diagnosis. A case like this is a young male who came to us with very high intraocular pressures, and you can see the iris atrophy, correctopia. You can see that the fact that the entire iris is atrophied. He had an Eisenfield-Rieger syndrome with a FOXY1 mutation. So this is a case of classic Eisenfield-Rieger. But look at this case, another case, similar case, a lot of iris atrophy, large corneas, and you can see that there is correctopia, and you can see the whirling of the iris also here. Now in this case, we thought it was an Eisenfield-Rieger, till we did sequencing, and here he turned out to be having a SIP1B1 mutation. So this is a classic case of a congenital glaucoma that manifests in the form of a similar phenotype as an Eisenfield-Rieger syndrome. This was another interesting case. This was a story that spanned decades. A patient, a young woman who had lost one of her eyes because of retinal detachment, was diagnosed as congenital glaucoma, was operated for congenital glaucoma, and when she came to me, when she was around 25 years old, she had this distal detachment total, which I thought was probably because of the surgery she had undergone during childhood. But then she underwent a DSEC, she was rehabilitated, and 10 years down the line she came back with a child. This was a child who had, again, a ophthalmic eye, half stripe, and a similar picture which had a very large corneas and iris which was atrophied. We probably thought that this was a classic case of congenital glaucoma because both the mother and child had it. I mean, I've never seen an autosomal dominant kind of a picture in a congenital glaucoma. When we look at the teeth of both the mother and the child, they had some dental anomalies, and dental anomalies are generally associated with Eisenfield-Rieger, so we probably thought it was a FOXY1 or a typical of Eisenfield-Rieger. But there was something abnormal. There was something abnormal in the face of these children, of this child and the mother. So we undertook a whole exome sequencing for this family, and we found something very interesting. There were genes which are associated with a condition called Seckel syndrome. So here, this was the first case report of a Seckel syndrome causing congenital glaucoma, and there were 3 genes actually with Seckel syndrome which the child was harboring. So it was a very rare case where it was not monogenic, it was not digenic, it was actually an oligogenic inheritance where 3 genes were contributing to the disease in this particular family. Genetic diagnosis is also important to provide appropriate treatment. This was another young boy who came to me when he was 10 years old. He underwent trabeculectomy in both eyes because his intraocular pressure was very high. He was high myope at that time. We had diagnosed him as a juvenile open-angle glaucoma. 10 years later, he came back. Again, his intraocular pressure was now 27 and 24. His disc was not so bad, but his cornea was very thick, and the axial length was more or less normal. And we did a repeat trabeculectomy because intraocular pressure was high. Now, 20 years later, he was born with a child who had this type of cornea. Can anyone tell me what is this disease? Any cornea people? Anyway, we didn't understand what was going on here. So the corneal diameter of this child was small. It was not a ophthalmic eye. He was highly myopic, and the child also had very thick corneas. The axial length was also not very large. So here was a father and the son having some sort of high intraocular pressures. The father was afraid that the son might have glaucoma. This is when we did his intraoperative OCT and we found that the cornea was highly convex, the keratometry was high, and there was some type of corneal disorder that this child had. We thought maybe it was a case of CHED, congenital hereditary endothelial dystrophy. So we subjected this family again to a whole exome sequencing, and we found that there was a gene which is known as the Z1, which is associated with a condition called the posterior polymorphous corneal dystrophy. So here was a family where the actual disease was a posterior polymorphous corneal dystrophy, and the father unnecessarily underwent trabeculectomy surgeries just because the genetic diagnosis was never made for the family. This was another interesting case, a case where a 2-month-old child was brought to me, sent to me because they thought it was a congenital glaucoma. The cornea was extremely opacified in both the eyes, and it was extremely thick, and they thought because the intraocular pressure was high, so probably they thought it was a congenital glaucoma. But it was only on genetic analysis that we realized that it was a congenital hereditary endothelial dystrophy because it had a SLC4A11 mutation, which was very typical of a congenital hereditary endothelial dystrophy. Sometimes it is very difficult to distinguish what is what, and it is at this time that you need a genetic diagnosis to actually understand whether it's a congenital glaucoma or a corneal dystrophy. Another interesting case was led us to actually diagnose the systemic nature of a disease only because he presented to us as a case of glaucoma. A young boy comes to us with very high intraocular pressure, optic atrophy, glaucomatous optic atrophy in one eye. There was no family history of glaucoma. He was highly myopic. And it was then that we thought that it was a juvenile open-angle glaucoma. We subjected him to a whole exome sequencing, and during this time we found that that his corneal diameters were on the smaller side, and he had a POL4A1 mutation. Now this particular mutation is associated with glaucoma rarely, but more commonly associated with small corneas, is associated with vascular problems, and is associated with the posterior endotoxin. So very strange kind of picture that these people have, and it is the posterior endotoxin which actually then led us to the diagnosis, because when we went back and looked at the phenotype, we did find that he had a posterior endotoxin. So this was something interesting because it was very subtle and it was only picked up on an ASOCT. So on careful examination, then we realized that this child also had a history of some birth problems when he had swelling, and on MRI also there were some hypointensive lesions. So we were able to find out of these patients, they can develop strokes at a very young age. It was then that we looked at the father. The father also was bearing the same mutation. While the father was absolutely normal, but when we measured his intraocular pressure, they were also very high. So we were able to diagnose ocular hypertension in the father, who also had a very subtle posterior endotoxin because of this particular mutation. So not only is it important to diagnose and to treat, but it's also important that you have to screen the family members. And we know that myosin mutation, which is very commonly associated with juvenile open-angle glaucoma and some adult open-angle glaucomas, there are a lot of variants in the myosin gene, some of which are associated with very severe disease, and some of these mutants are associated with a very high penetrance. That means a lot of members of the family are affected. This particular mutation, which is the RGE 367, is associated with a large number of families. You can have 20, 30 members in the same family with the same mutation. And if you are able to even pick up in one of these members, you can screen a large number of families, family members to actually make a diagnosis. But genetic diagnosis may not always be helpful. Sometimes it's important to do other things. For example, in this particular family, there were 2 children born in the same family having the same mutation in the CYP1B1 gene, which was a very severe kind of homozygous mutation. But one of these children had a very good prognosis. This child was followed up 5 years later, and she's doing very well, but the other child actually lost one of his eyes. And the reason why, despite having the same mutation, was that this child was picked up early because because she came earlier and was diagnosed and treated earlier. But during COVID, the other sibling was never came up and came late, and so was unable to be managed early. So taking in congenital glaucoma, it's like an emergency. You have to manage them as early as possible, and if you can then restore vision and rehabilitate them compared to children who come very late. So it's important to take them in as early as possible. So to summarize, I would like to say it's important to make correct diagnosis and decide treatment, and genetics really helps you in doing that. But of course, you need a lot of patience, a lot of work. Sometimes I had to go back to the diagnosis, back to the phenotype, back to the genotyping again, because I was doing everything myself. I was doing the genetics work, I was doing the management of these children, the management of the families, all as a single person. It was too much of work, but then you have to do all of this because it becomes an addiction when you love to do it. Then, of course, there are important caveats to genetic diagnosis, because the counseling that you give to these patients can be extremely tricky. Where it has come from and what has happened to them can be extremely difficult. So I founded the Indian Pediatric Glaucoma Society primarily because there was a lot of pediatric glaucoma in our country. There was very few pediatric glaucoma specialists in the country, and we needed a society where we could all get together and share views, because as far as pediatric glaucoma is concerned, we have the largest numbers in the world. So we have a meeting which is next month, and anybody who is interested in pediatric glaucoma is most welcome to attend this. So thank you for your attention.
Disease in just 5 years, and then I looked at the percentage. 19.3% came out as neoplasms. So I realized that 10,000 new eye cancers per year was diagnosed, and 20 to 30% was in children. Retinoblastoma is the most common, about 2,000 cases annually in India, which might have increased, but the registry says so. At Aravind Madurai, at the time when I was starting my oculoplasty journey, we saw about 40 to 60 cases per year. So the first strategy I used was, I needed to bring in visibility. This is for the youngsters to understand. If you want to pursue any of your personal passion, the first thing is you have to bring in visibility. So I made my first presentation in the International Ocular Oncology meeting, which is where a lot of big players at that time came in to speak with us. I had a poster put up, so Dr. Shields, all of those people came, and there is one lady who lost her child but never fails to come during.
Sir, next award, the most prestigious.
Where you have half the professional life is getting over. Once you open your eye, what you have achieved, this is a testimony award for that. So I would say this is a testimony award, and they should shy away from it. Okay? Then this is for this state, either born or served for this state. So it's totally committed for Odisha Ophthalmological State and Odisha Ophthalmological Society. So these two are clear. Number 3 is 20 publications should be there, because that's how science can develop in this state. So everyone should aspire minimum 20 publications should be achieved to be eligible. First of all, getting the award is for to be eligible. Then service to the society or the credibility of the publications and all.